Well, the truth is, I couldn't, in good faith, argue that surgery has no role in treatment of metastatic neuroendocrine tumors, because that contradicts what I do on pretty much on a weekly basis, which is refer patients with metastatic disease to a surgeon. So I decided to reframe the question a little bit and ask, is there evidence for a role of surgical resection of metastatic nets? And perhaps even more pointedly, ask whether there are claims in much of the surgical literature that are not really supported by the level of evidence. So as Dr. Chody explained, when we're talking about surgery in metastatic neuroendocrine tumors, we're rarely talking about potentially curative surgery. What we're talking about much more often is debulking surgery, and these are basically R2 resections of predominantly liver metastases with the goal of typically of removing 90% of disease through a combination sometimes of resection and ablation, although that 90% has been recently a moving target. We're also often talking about resection of the primary tumor combined most often with a mesenteric lymph node. And as you may know, these mesenteric lymph nodes can produce quite a bit of desmoplastic fibrosis, which leads to tethering of small bowel and obstruction. What is the evidence of benefit? Well, we're always talking here about retrospective series in which survival in patients undergoing surgery is relatively long. And relatively long compared to what? Well, sometimes compared to patients in the same institution who haven't undergone surgery, sometimes compared to just an average of patients with metastatic disease on the SEER database or in other national databases. But of course, we're talking about a comparison between surgical outcomes and outcomes in patients not undergoing surgery that are non-randomized. And when you're comparing such different populations, the sources of bias are tremendous, and I'm going to go through those in detail in a few minutes. But clearly, a very low level of evidence comparing patients undergoing surgery to patients not undergoing surgery. But what is the language that is used? Well, this is an article that Dr. Chody just quoted, a plea for resection to increase survival. And if you look at the conclusion section, it says, debulking extends survival, although recurrence is expected. Hepatic resection is justified by its effects on survival and quality of life. So really an implication of cause and effect. Surgery causes improved survival. Not correlated, because correlation doesn't necessarily imply causation, but a cause and effect. Is that something that we really know? Here's another manuscript on operative resection of primary carcinoid tumors in patients with liver metastases yields significantly better survival. So again, this cause and effect language between resection of primary and improved survival. And in fact, they come to the bold conclusion that resection of the primary may deprive the patient of a constant source of hormones and growth factors that accelerate their proliferation. Really a claim that is quite unusual, that resection of the primary influences the progression of metastatic disease simply because patients with metastases live longer. Patients with who undergo surgical resection have lived longer than patients who did not. And we've been guilty of the same sort of language at Moffitt Cancer Center, where we compared cytoreduction versus liver embolization and concluded that cytoreduction resulted in improved symptomatic relief and survival in this non-randomized study. So again, an implication of cause and effect. But what's the problem? Problem is confounding variables, selection bias in non-randomized comparative studies. And we all know that patients referred to surgery have completely different patient characteristics as well as tumor characteristics compared to patients not referred to surgery. And these includes age, performance status, comorbidities. They include tumor-related factors such as grade, such as pace of growth, number of metastatic sites, both number of liver metastases and pattern of distribution of liver metastases. So really a group of at least 20 prognostic factors that might distinguish patients referred to a surgeon versus patients not referred to a surgeon. Oh, wow, this didn't come out very well, the slide. But, there's obvious differences between the pattern of metastatic disease in a patient who's a surgical candidate versus not a surgical candidate. And in fact, even when you look at the second CT scan and you talk about tumor burden, well, perhaps these two patients on the left and right have similar tumor burdens, 60, 70%, but of course, in a completely different distribution. Most of us would agree that the patient on the left would likely benefit from a right hepatectomy, maybe an extended right hepatectomy, whereas the patient on the right side is clearly not a candidate for cytoreductive surgery, despite equivalence of tumor burden. There have been studies looking at outcomes in patients with resectable versus patients who underwent resection versus did not undergo resection of the primary tumor that didn't even factor out patients who had unresectable tumors. So obviously the outcomes are quite different. And if you look at this patient on the right side with an unresectable mesenteric mass that's producing this desmoplastic reaction that's tethering the bowel, that's probably causing mesenteric venous ischemia, this is a patient that's very likely to have poor outcomes simply because of bowel dysfunction. Malnutrition. And so comparing these two populations is really not a legitimate comparison. So I attended a meeting a few weeks ago where a panel of surgeons was talking about the role of cytoreductive surgery and resection of the primary, and an audience member asked the question, when will we stop having these debates and finally have a prospective randomized study? And the answer they gave was hopefully soon, but actually I don't think that's a very realistic answer. Because if we consider the fact that patients with relatively limited metastases, predominantly with midgut neuroendocrine tumor, have a life expectancy exceeding 10 years, we're talking about a study that would probably require many thousands of patients and perhaps a 20-year follow-up to even begin to answer this question. When we consider that many patients randomized to non-surgery will eventually cross over and undergo surgery, which will reduce the power, we're not really talking about a study that's realistic. We also have to ask the question, would patients even be willing to be randomized to surgery versus no surgery? I think the answer is probably not. I personally, if I were a patient with a metastatic neuroendocrine tumor, would not want to have this answer determined by a coin flip. And of course, how do we define equipoise, where we can really say we don't know whether a patient X is going to benefit from surgery or not? Do we define that in patients with one or two metastases? Do we define it in patients with a larger number of metastases? Do we define it in patients who have 90% debulkable disease or a lesser percentage? So the realistic answer is that we'll probably never have a randomized study of surgery, that we're going to be debating this for probably eternity, and that we're going to have to use clinical judgment and common sense. We'll never have a high level of evidence to support this, but we'll have to really base our decisions on common sense and on clinical experience. Thank you.